in males. When the testes descend and push that bubble of peritoneum down into the scrotum, that bubble doesn't get sealed off to form a separate structure in front of the testes. Rather, there remains a continual opening from the peritoneum up in your abdominopelvic cavity to a little bit of a bubble of peritoneum lying in front of your testes, so bits of abdomen can just follow that same pathway all the way down. That's called an indirect hernia because it's like the inguinal canal. It starts over here, passes through all the same layers that the spermatic cord does, and again ends up in the scrotum. So it just passes through the canal, goes from lateral to medially, and it's more common in males than females because it's usually congenital. It's usually related to the fact that when the testes descend, they didn't close off the opening between the scrotum and the peritoneal cavity. It turns out that artery and vein that I told you was coming off of a little artery down here and right on the edge of the abdominal pelvic cavity, that inferior epigastric artery travels up along this, and if you superimpose the inguinal canal over that, it turns out that the deep inguinal ring is lateral to it, and the superficial inguinal ring is medial to it. So if your hernia is a direct hernia, it's just poking through that superficial ring, you can feel this artery pulsing lateral to it. If it follows the same pathway, the bulge starts out here, you'll see the bulge lateral to that artery, and that's just a simple clinical way of telling where the hernia is actually coming from. And this is the same thing yet again, but here showing a little hernia. So right here's the inferior epigastric artery coming up here. Here's your superficial ring here, and the bit of bowel just sort of pushes through where that superficial ring in the external oblique, which is coming down here, pushes through that superficial ring. You see a bulge medially. On the other hand, the indirect hernia, the bit of bowel follows the same path that the spermatic cord does and the testes does. It just follows the inguinal canal itself from over here in the deep ring underneath all these muscles and goes in like that. Here's a more graphic display showing a bit of bowel pushing its way down the inguinal canal and going down along the spermatic cord. As you can see, when it goes from something this shape to something in there, the chances of it getting tied off and losing its vasculature and getting infected are pretty high. So it has to be fixed. And in case you didn't pick it up in the last 15 minutes, the parts of the anterior abdominal wall are continuous with the stuff covering the testes. We're not going to dissect testes. We're not going to open this area up. And we really won't open up the spermatic cord, but you should know that these layers are continuous and know how hernias form and why that's of some clinical importance. Okay, so today is the anterior abdominal wall. Tomorrow, the first thing you come in, or if you want to do it today, more power to you, we will open up that anterior wall after you've found all the layers and know how they're oriented and what the muscles are. And then you'll start looking at abdominal contents. Okay, I think so you'll find a big liver up here and a stomach here and a spleen back over in this corner and a lot of small intestine here and here and here and then large intestine going around there. I'm not going into those organs. Dr. Wilberg will go over them in great detail with you tomorrow's lecture and the lecture after that not tomorrow, Friday, and the lecture on Monday. But what I want to do is give you sort of an introduction as to how the abdomen itself is sort of organized. And this will seem like deja vu all over again. Because you'll remember when we talked about lungs, we talked about this complete sac. Trash bags are an all-purpose anatomical display. So we talked about all these troubles, and in the cavities on either side of the thorax, you had a lung that pushed its way into this cavity, and you had visceral pleura surrounding the lung tissue and parietal pleura on the outside, all right? And then when we got to the heart, you had the sac, and you had a heart pushing into the sac, and you had visceral pericardium lying around the heart and parietal pericardium on the outside. But that one was a little funnier because it also had that fiber stuff on the outside. The same is true in the abdomen. This is a theme in developmental biology. But there's a slight twist to it. So this is a bit of gut, small intestine, large intestine. And just as the lung pushes into a sac, heart pushes into a sac, the organs of the abdomen push into the sac. Okay? Okay, that's cool. And then you will have, this sac is referred to as peritoneum. So you have parietal peritoneum out here lining the abdomen. You have visceral peritoneum covering the outside of the organs. And then you have a space in between, which has in it nothing except a little bit of fluid so that these guts slip and slide. Needless to say, there are problems. Sometimes you can get an infection in there, and you'll see tomorrow it can go from top to bottom, and there are ways of getting at it, and so forth and so on. So it's the same story with visceral peritoneum and parietal peritoneum. There is a twist, which I won't talk about today, but sometime in the next few lectures. Unlike the lungs, which always, push in there and stay in the pleural sac, or the heart, which pushes into the pericardial sac and pretty much stays there, these abdominal organs are a little bit quirky. Some of them say, fine, I'm happy to stay in here. Some of them say, I'm tired of this, I'm lazy, I'm going to go low against the back wall. And then it gets sort of funny, but we'll talk about that in a few days. The point I want to make on this one is that unlike the pericardial sac or the pleural sac, where you have the structures just sort of sitting there, in the gut you have mobile tissues, right? The small intestines, a whole big loops of garden hose that are flopping around and going everywhere. What happens is these organs push into this peritoneal sac, and they're often sort of suspended from the back wall. So they're sitting there like that. They are suspended from the back wall by this double layer of peritoneum, which is called a mesentery. So you'll read about mesenteries are these double layers of peritoneum, so the stuff is hanging off the back wall. Well, obviously, if these are living tissues, they have to have arteries, veins, and nerves to do their job. And the arteries, veins, and nerves, which are all coming off the back wall, mostly from the midline of the back wall, travel from the back wall and their source to these organs within this mesentery. Okay, so mesenteries are not just suspending the organs from the back wall, but they are through the conduit through which their blood supply comes and goes and their innervation comes. So when you see bits of small intestine hanging out there, realize that this mesentery has the arteries and veins and nerves inside it, and in some cases you'll be asked to dissect them out. So realize this is the same organ pushed into a sac, but it's a little bit different because the layers of the sac are attached to the back wall and they're carrying blood and innervation in there. So let's look at some pretty pictures of this. So here's the layers. So here's what we've talked about. Right, here's the skin, and here's your Camper's fascia and your Scarpa's fascia, and then your various abdominal muscles that we've talked about. Okay, then you've got your transversalis fascia down in there. Then you got more fat, and then you've got your peritoneum. This is your parietal peritoneum, lining everything. Surrounding this organ is visceral peritoneum, and connecting the organ to the back wall where the arteries, veins, and nerves are coming from are these mesenteries, which are a double layer of this peritoneum. So when you're reading for Friday's dissection, you'll hear about this mesentery and that mesentery and realize that's what you're going to see when you open things up. Here's visceral peritoneum. This is parietal peritoneum. This is the peritoneal cavity, which, like the pleural cavity and like the pericardial cavity, ideally has nothing in it. Okay. Now, these are the gut things. Most of the gut things. Okay. The stuff that the parts of the gut that are hanging out inside here, surrounded by their visceral peritoneum and hung to the back wall by this mesentery, okay, are referred to as intraperitoneal because they are within the peritoneal cavity with their covering. There's a whole series of other structures, the inferior vena cava, the abdominal aorta, the kidneys, the suprarenal glands, that don't have anything to do with this peritoneal system. They're just sitting there on the back wall, and they are called extraperitoneal or retroperitoneal. Extra because they're outside of this whole peritoneal setup, retro because they're on the back wall. Okay? For examples that you will see when you open things up tomorrow, the stomach, totally surrounded by visceral peritoneum and sort of attached to the back wall of the spleen. Part of the duodenum dangling out there. The spleen's dangling out here tied to the back wall. Jejunum and ileum parts of the small intestine are fine. The transverse colon, fine. It gets more complicated with other organs. Some organs say, well, yeah, this is all great, but that's too much trouble. And they sort of flop against the back wall and things change. And they're referred to as retroperitoneal, but secondarily retroperitoneal. Because they start off having a mesentery, but in development they just get lazy and end up being behind the peritoneum. We'll talk about that in the next couple of days. So, but when you're reading about these things, realize the peritoneal relationships are a little bit more complicated than the pleural and pericardial. Okay, that's it. Like I say, today you're doing anterior abdominal wall. If you finish all those structures and want to open it up and start looking around on the inside, by all means. We will see you on Friday. For the moment, still here. And like I say, if there are parts of the thorax that you think are funny looking, you want to show the pathologist, try to remember that when they come in on Friday.
Because I moved it. Because it goes off.
And congratulations on doing so well on the exam.
So putting my water bottle in, and I was like, that was really hard. Tony, how do I end it?